Hello and welcome to the EDS Echo Summit on fatigue. My name is Alan Pocinki, and I'm going to be giving an overview of common causes of fatigue in Ehlers-Danlos syndrome, assessment, and some basic principles of management. I will discuss some off-label uses of medication. I have no relevant financial conflicts of interest to disclose. So, I think it goes without saying that a thorough history, physical and laboratory testing is sort of the first step in the evaluation of fatigue, because fatigue, of course, is a common symptom of many illnesses. More specific testing related to fatigue and Ehlers-Danlos syndrome includes sleep testing, nutrition evaluation, and testing, or at least assessment, of autonomic dysfunction. And of course, the thorough evaluation of these areas is critical because treatment plan will be based primarily on the results of the evaluation. And you'll see that as we go through the talk. So many things contribute to fatigue in patients with Ehlers-Danlos syndrome. What I found are the big three are pain, poor sleep, and depression. And this vicious cycle of chronic pain, poor sleep, fatigue, and depression is unfortunately very characteristic of a number of chronic pain syndromes. Autonomic nervous system dysfunction both contributes to fatigue and being caused by fatigue, and we'll talk about that in a little more detail. Metabolic factors are common and contribute generally relatively small amounts to fatigue. A major factor in fatigue that I don't think needs further embellishment is inadequate rest. We're all very busy. We'll have too many things to do, too many things on our plate every day, and we just don't have the opportunity to take the rest breaks and take the downtime that we need. And pushing through pain and fatigue just makes everything worse. Cognitive tasks can be just as draining as physical tasks. Emotional stresses are draining, and unfortunately, stresses of everyday life seem to be getting worse all the time. So here's a graphic just to again show this cycle of how pain and fatigue and depression and poor sleep all go hand in hand. Each one, unfortunately, tends to aggravate the others. So these need to be treated as an ensemble. So, for example, if you're as long as you're in pain, your sleep will never be restful, your depression will never get better, and fatigue will still be a problem. As long as you're depressed, you'll be more sensitive to pain, you won't sleep well, and lethargy and fatigue will remain problems. So, and of course, there is no magic formula, there is no magic pill, because everybody's symptoms are different, everybody's response to treatment is different. So, if only this were the case, here's a woman watching television, and the TV commercial says, "Ask your doctor if taking a pill to solve all your problems is right for you." Wish it were so. All right, so let's go through these big three first. How does pain cause fatigue? Well, just pain in general just saps your energy. Anybody who's dealt with pain realizes that it's just tiring. Pain limits your activity. If you're in pain, you're going to be less active and fall into another vicious cycle of the worse you feel, the more you sit around, the more you sit around, the worse you feel. And that can be a hard cycle to break. Pain disrupts your sleep. Every day I see people who tend to underappreciate how much of a factor pain is in ruining the quality of their sleep. Chronic pain, we know, causes depression, and there are a variety of other mechanisms by which pain can contribute to fatigue. One is via cortisol. Cortisol is one of your body's major stress hormones. Typically, in response to stress, you make cortisol and you make adrenaline type compounds. And signs and symptoms of too much cortisol are typically weight gain, especially around your abdomen, your face, and characteristically your upper back. Acne, flushing, headache, thin skin, easy bruising, slow healing is something Ehlers-Danlos patients have already. Weakness, severe fatigue, irritability, trouble concentrating. Increased blood pressure is the one thing that Ehlers-Danlos patients typically, of course, don't have. But when I show this slide to patients, or I have a handout like this, people quickly check off all or most of these things. So one of the big things about management of pain I always tell people, don't underestimate how much pain you're in. Uh, when I try to convince people that they're in more pain than they realize, I get responses like, oh, it's not that bad. I'm used to it. I've learned to live with it. I don't want to be taking pain medication. These are things I hear regularly from patients in pain, but these are not helpful approaches to managing chronic pain. Um, I try to explain the concept of background pain, that when you're in constant pain, your body eventually sort of ignores it. Um, and you really aren't consciously aware of how much pain you're in. And the other thing is that some of these stress hormones that your body makes can actually mask the pain and help you not realize how much pain you're in. So I found that breaking pain into different types is helpful in trying to determine what might be the most appropriate treatment. So some pain is inflammatory. Um, Ehlers-Danlos is not primarily an inflammatory condition, but the constant strain of muscles trying to hold loose joints in place is typically inflammatory. And so anti-inflammatory drugs like ibuprofen can be helpful for that. For most people, again, this is a small component of their pain. In Ehlers-Danlos or any of the hypermobility spectrum disorder or any of the hypermobility syndromes. Um, Mechanical pain is a bigger factor, and that I describe mostly as the chronic strain of muscles around loose joints tends to cause them to tighten up, and this tension tends to pull on what we call stretch receptors, and that generates pain. So physical measures like heat and physical therapy or dry needling or massage can often be helpful. Muscle relaxant medications tend to be sedating, but used at bedtime, they can help improve sleep quality by reducing pain overnight. Uh, some pain can be neuropathic. That can be pinched nerve pain, or in severe pain syndrome, something called allodynia, where even light touch can be painful. And medications for treatment of that are listed here. One I should add is also low-dose naltrexone. Some people find helpful for neuropathic pain. So not to be overlooked are non-pharmacological treatments for pain. Again, you're not taking a pill for everything. Physical therapy is very helpful, often including dry needling or myofascial release or other physical therapy modalities. Exercise itself can help loosen tight muscles and reduce pain. Acupuncture, many people find helpful. Various pain relieving devices, such as transcutaneous electrical stimulation, some people find helpful, especially for localized pain like neck. So medications for pain, I think the main point I make with this slide is just how short the list is. That there's Tylenol, there are the NSAIDs, and there are the antidepressants that have pain relieving effects, such as duloxetine. There are the neuropathic pain drugs, such as gabapentin and pregabalin. Other medications, such as muscle relaxants, can be helpful. Topicals, like creams and gels and patches of various kinds, can be helpful. But if you've gone through all those things and your pain is still not well managed, you might need opioids. And I know this is a controversial thing, but I have a large number of patients who couldn't sleep without taking an opioid at bedtime, or wouldn't be able to work without taking opioids for pain control during the day. In the US, more and more states now have approved the use of cannabinoids. My experience has been that most patients do not find cannabinoids particularly helpful for pain. They're helpful for anxiety, for sleep, sometimes for nausea and appetite. But again, everybody's different, and some people do find them helpful. So, like pain, it's very important to not underestimate your depression. And again, like pain, patients say, well, it's not that bad. I'm used to it. I've learned to live with feeling this way. I don't need counseling. That's not going to help me. I certainly don't want to take antidepressants. And then the very understandable response, of course, I'm depressed. Wouldn't you be? And these are things I hear regularly for patients, but this is really not helpful approaches to managing depression. And one important point I always like to make here is that you don't have to be sad to be depressed. A lot of people think that, well, I'm not gloomy, I'm not sad, I'm not hopeless, I'm not all these things that, You can be just tired and unmotivated and have trouble concentrating as your primary symptoms of depression. Um, and then another point that I've sort of learned over the years is that neurotransmitter deficiencies, so low levels of things like serotonin and norepinephrine, can be significant even in the absence of obvious symptoms of clinical depression. Um, and again, not a pill for everything. Don't overlook non-pharmacologic measures to help your depression. Counseling can help. Exercise certainly can help mood and help sleep. Various relaxation and stress management techniques can improve your mood. And spending time doing things that you enjoy, spending time with family, spending time with hobbies, spending time with pets. And here's a fun cartoon where this woman is choosing to get some TLC from the huggist rather than getting medication from the druggist. So, like pain, different types of depression respond to different pharmacological treatments. Um, I've found it helpful to group depression symptoms into those that are typically serotonergic, anxiety, irritability, worry, obsessive compulsive type features. Um, those that are more associated with norepinephrine, fatigue, pain, cognitive impairment, cognitive symptoms. Those related primarily to dopamine, which the big one here is sort of motivation, pleasure, reward, looking forward to things, enjoying things when you're actually doing them. And then uncommonly, but always need to watch out for people depressed to make sure that they're not actually bipolar. Um, and I'm a visual person, so here's a visual for this that I borrowed from a very old pamphlet. And I'm showing this, and this is oversimplified to a great extent, but this is very helpful, frankly, for me, but also explaining to patients who may have been put, for example, on a serotonin type antidepressant and say, okay, I'm less worried, I'm less anxious, I'm less depressed, I'm sleeping better. But man, I just still don't feel like doing anything and I'm having trouble concentrating. So reassuring them that these are, these are symptoms that we don't really expect serotonin drugs to improve. That these symptoms will generally not improve with just a serotonin type antidepressant. So, and here's another cartoon, again, along similar lines as the last two. This woman who's coming back to the doctor after having been started on antidepressants says, I think my dosage needs adjusting. I'm not nearly as happy as the people in the ads. So, as a reminder, sort of be realistic of your expectations. No pill is going to melt all your problems away. So let's talk about sleep, the third leg of the three-legged stool, if you will. And similarly, different types of sleep problems require different treatments. If your primary problem is falling asleep, that could be an anxiety problem, that could be from pain, that could be a restless, fidgety thing, that could just be the idea of hyperarousal. I'm not anxious, I'm not worried, I'm not in pain, I'm just awake. Don't overlook environmental factors. A comfortable mattress is important. People who have any autonomic issues will tend to be more sensitive to small amounts of noise and light. And hard as this can be to address, I do see a lot of patients who have to send their noisy bed partner to a different room in order to be able to sleep well. And frankly, sometimes the bed partner turns out to be a pet, and a surprising number of people sleep with their pets, and their pets get hungry at 5 a.m. and wake them up. If you primarily have trouble staying asleep or wake up often and have trouble getting back to sleep, that's a different problem. That can be pain related. That can be a breathing problem like snoring or sleep apnea, or it can just be frequent or vivid dreams that are waking you up, disrupting your sleep. And then very often in Ehlers-Danlos and the hypermobility spectrum disorder and the hypermobility syndromes, people fall asleep okay, sleep through the night okay, and just wake up feeling like they haven't slept. They just wake up feeling unrefreshed. And I'll show you an illustration of that in a minute. So very much, again, you recognize the theme here, like pain and depression. Don't underestimate how bad your sleep is. This is a little more difficult because you're asleep and you don't realize how bad your sleep is. But similarly, people say, well, the typical response I get from an Ehlers-Danlos or HSD patient to how's your sleep is not terrible. which is a pretty low bar. It's not that bad. I'm used to it. I've learned to live with it. I've never been a good sleeper. I don't want to take sleeping pills, are things that patients who don't sleep well will often say. But again, these are not helpful approaches to managing your sleep disorders, and recognizing that poor sleep is a major factor in fatigue and mood and even autonomic function uh, is important. So perhaps even more so than with pain and depression, people misperceive their sleep, and they'll say most sort of quintessentially, they'll say, I'm a great sleeper. I can sleep anytime, anywhere. I can sleep 10, 12 hours, no problem. I can take a 2-hour nap anytime. And these people are often very disappointed when I explain to them that that means they're actually not good sleepers, that if you sleep, you shouldn't need to sleep 12 hours. If you sleep 12 hours, you shouldn't be able to take a nap. You should be rested. Um, and we know from studies with patients with sleep apnea and with periodic limb movements of sleep, they often are totally unaware that they're having these problems. And the most common pattern, which I'll show you in a minute, that we see in Ehlers-Danlos and HSD is a sleep disorder that's characterized by frequent arousals or disruptions to the continuity of sleep and a lack of deep sleep. And these really don't cause any particular symptoms except feeling tired when you wake up. So sleep studies can be very helpful, but only if they're carefully interpreted, meaning if the person who's looking at them kind of knows what they're looking for. And that, by and large, is almost never the case. Home sleep monitors can be very helpful. The newer iterations of things like Fitbits have reasonably accurate sleep data and can be helpful in assessing, especially response to treatment. If that kind of thing is not available, a simple heart rate monitor can be helpful in seeing what's going on overnight. If your heart rate is bouncing up and down all night, or if your resting heart rate overnight is not lower than it has been during the day, those are signs that your autonomic nervous system is overactive and that's a problem with your sleep. So graphically, again, pictures are, I think, for me, better than text. These are sleep stages through the course of the night. So in a healthy person who's sleeping well, they'll spend a little time in shallow sleep, then get a chunk of deep sleep, shallow, REM, shallow, usually a little more deep sleep here, shallow REM, shallow REM. So you see there's a fairly regular cycle through the night of shallow sleep and REM sleep, with most of deep sleep early in the night. The lower picture is a very common pattern in EDS and HSD. And you already know now enough about sleep to say that this doesn't look right. There's no deep sleep. There's no REM. There's nothing that looks like a cycle. This person is just stuck in shallow sleep the whole night. And other than this one period when she was awake, she wasn't aware there was anything wrong with her sleep. And sadly, this lower bar was read as a normal sleep study by a board-certified sleep doctor. So this is an example of what we call a hypnogram, which allows us to look at various different things going on during the night simultaneously. So the top frame are sleep stages. And so here's, you'll see that the top line is awake. So all the bars, all the lines that go all the way to the top are awakenings. And then you can look and see, well, here's the person's oxygen level. That seems okay. There's their body position. That seems like maybe they sleep a little bit better when they're on their right side. But most strikingly here is looking at their heart rate. And if you had a ruler, you would see that almost all the awakenings line up with spikes in the heart rate. And also I included this slide because for whatever reason, you'll see here, the heart rate was calm and steady. The autonomic nervous system was quiet, as it should be during sleep. And this person got an almost interrupted nice chunk of deep sleep. But the rest of the night, they're waking up 25 times and their heart rate is bouncing up and down all night. You can see that the lower frames show apnea and breathing episodes, and you can see that was not an issue at all for this patient. So don't overlook the basics. Mentioned earlier, good sleep hygiene. Don't, take your phone to bed with you. Don't lie in bed watching some scary movie or something really stressful late at night and then expect to turn off the lights and fall asleep. Again, dark, quiet, comfortable mattress. comfortable temperature. And then, yes, sleep apnea should be treated and any limb movement disorders should be treated, but only if they're significant. Often I'll see patients who have 125 or 150 disruptions to their sleep, and maybe 25 of them are apnea related, and they're diagnosed with apnea and sent home with a mask, and then wonder why they doesn't seem to be helping their sleep at all. So, what to do about your sleep? Unfortunately, addressing all these issues often requires a combination of medications. At the very least, something to increase deep sleep and something to reduce the arousals. But if some of the arousals are related to pain, taking pain medication at bedtime is often helpful. And again, many of my patients are surprised when they take a pain medication regularly at bedtime that it does improve the quality of their sleep. And finding the right combination can be frustrating both for doctor and patient because, again, everybody's different. It's going to have different responses to medication. And as I mentioned earlier, home sleep monitor can be helpful. If you try a new medication and say it reduces the number of your arousals by half, you're not going to wake up the next morning and say, oh, wow, that was so much better night's sleep. But if your sleep monitor shows you some improvement, then you'll know you're on the right track. And then over time, you'll actually feel some benefit from that. So won't spend a lot of time here. Medications useful for addressing these sleep problems are medications that block the extra adrenaline that's driving the heart rate up and driving these arousals in many HSD and EDS patients. Histamine is an overlooked culprit. Histamine this is the same histamine that makes your nose run and your skin itch, is a very stimulating neurotransmitter. So I see a lot of my mast cell patients who are taking H1 blockers to block the histamine in their skin and their respiratory tract, and H2 blockers to block this histamine in their GI tract, but they're not taking anything to block the extra histamine running around their brain. And that can be contributing to sleep disruptions. And diphenhydramine and hydroxyzine are two older antihistamines that do get into the brain and can often improve sleep. I just saw somebody yesterday on a long list of medications and already, and she was surprised at how much adding a small dose of hydroxyzine at bedtime had helped. Benzodiazepines basically raise the levels of calming neurotransmitters to offset the extra stimulating stuff. As I mentioned, pain medications often help. People underestimate how much pain they are in overnight. And then medications to increase deep sleep. There's a very short list of medications that actually have been shown to increase deep sleep. Trazodone, probably the most effective, but gabapentin and pregabalin, since they both increase deep sleep and reduce pain, can often be helpful as well. Conventional sleeping pills, and that's primarily zolpidem, Zaloplan, and ezopiclone, don't do anything to reduce arousals or increase deep sleep. So really are generally not helpful unless you really can't fall asleep any other way. So very quickly talk about how the autonomic nervous system plays a role in fatigue. For those of you new to the ANS, it's basically the part of your nervous system that regulates everything that goes on automatically, your circulation, your breathing, your digestion, your body temperature, and in fact, your sleep. Its job is to keep everything in a steady state on an even keel. And it primarily has two components: the sympathetic nervous system, which is your fight or flight response, which I liken to a car's accelerator, and the parasympathetic nervous system, which is more active in resting and digesting, and is the brake to slow you down. So autonomic dysfunction is very common in Ehlers-Danlos syndrome and the hypermobility spectrum disorders, and it's primarily characterized by a failure to maintain stability, that things fluctuate when they should be calm and steady. And the central feature of autonomic dysfunction in these syndromes is a tendency to overreact to minor stresses. And I'll show you what that looks like graphically. So won't show you all of this, but and this is an autonomic testing equipment that measures sympathetic and parasympathetic activity. In this part of the test, I keep losing my cursor. In this part of the test, we ask people to stand, and in a healthy functioning autonomic nervous system, there's a drop in blood flow as you stand, and then the body kicks in a little extra adrenaline to raise the heart rate, raise the blood pressure, maintain blood flow to the brain. But then very quickly, your body does other things like constrict blood vessels and move blood in from other places into the bloodstream to maintain blood flow to the brain, and there's no extra adrenaline needed. This is what happens in a patient with Ehlers-Danlos or HSD or a number of related dysautonomias. Blood flow to the brain drops, and instead of this small increase in adrenaline, there's a much bigger increase in adrenaline. And then essentially the pressure sensors in the neck say, wait a minute, now the blood pressure is going up too much, too quickly. We better slow it down. And you hit the brake even harder almost immediately. And I have some patients who feel this, and it literally happens within seconds. And then blood pressure and heart rate drop. And this is how a lot of people faint. People with autonomic problems tend to faint. But then you can see this person then recognizes that, okay, that was too much brake. Now I need to hit the gas again. No, that was too much gas. Got to hit the brake again. No, too much brake. And you see just how much energy is getting wasted here just trying to maintain blood flow to the brain compared to here. First part of the test, the patient is just sitting quietly, but the patient with autonomic problems is still cranking out adrenaline. So simple tasks like maintaining blood flow to your brain when you sit or stand are wasting energy. Unfortunately, the more tired you get, the worse this becomes. So in terms of fatigue, these fluctuations, this tendency to overreact to minor stresses tends to waste energy that you're trying to conserve. I've just shown you how autonomic dysfunction impairs sleep quality. So that's another way in which the autonomic problems can contribute to fatigue. And we've talked about medications that then can reduce autonomic dysfunction and help reduce the fatigue associated with it. So overall, I hope I've sort of shown you here that different causes of fatigue obviously require different treatment. Most of the fatigue in EDS and the hypermobility spectrum disorders comes from poor sleep, chronic pain, depression, and autonomic dysfunction. These are especially the first three I've started referring to as a three-legged stool. If you only treat two of those three and the third leg is weak, what happens when you sit down on the stool? So you really need to address all of these things. Of course, it doesn't mean these are the only causes of fatigue. There are metabolic factors that you need to look for as well. And let me just quickly go through a few common ones. So things like anemia and hypothyroidism are common because they're common in the general population. So they should be micronutrient deficiencies, the most common and most symptomatic ones I see, the most clinically significant ones I see in EDS and HSD are vitamin D, B12, and magnesium. Hormone deficiencies, especially deficiencies of DHEA and testosterone, can be factors in fatigue. Salt fluid imbalance is a major problem. And as I alluded to, mast cell dysfunction can affect fatigue in many ways. So D, the major point to make about vitamin D, normal levels between 30 and 100. Recent studies are suggesting that optimal is probably over 50. If your level is 20, just to get your level up to 40, typically takes about 1 million units of D. And in the US, the recommended daily allowance is only 600 units. I've found most people need about 1,500 units just to maintain their level. And if you're trying to raise your level by 20 points, you're going to need to take something like 5,000 units a day or 50,000 units a week. Otherwise, you'll just be deficient for several years. B12 deficiency, similar idea that low normal is often not normal. Normal level often is listed as 200 to 1,000 or 200 to 1,100. Patients I see are below 300 are always deficient. The most severely B12 deficient patient I ever saw had a blood level of 320. So be wary of low normal levels. And of course, B12 deficiency can contribute to fatigue, cognitive problems, depression. So it's something that you really don't want to miss. And I recommend, even if you're not sure whether you might be deficient, a short trial of vitamin B12 injections is worth doing to see if it improves any of your symptoms. Magnesium, kind of like vitamin D, only 1 or 2% of your magnesium is in your bloodstream. Most of it is in your cells. So a standard blood test for magnesium level isn't very helpful. Red blood cell magnesium levels are a little more helpful. if you're low in magnesium, it takes a ton of magnesium to correct your deficiency because all your body cells need it. Um, and kind of like the 600, taking 600 units of vitamin D to correct your D deficiency, taking an oral magnesium supplement to correct your magnesium deficiency is like filling a bucket with an eye drop. Um, Testosterone deficiency, I noticed many years ago that a number of my younger women patients, even once they were sleeping better and feeling better and getting more exercise, still were not building muscle. And they turned out to have very low testosterone levels, total testosterone in the single digits. Um, Treating women with testosterone is very controversial, and experts, the expert societies in the U.S. Recommend against it. But I found a lot of patients do feel better when supplemented and have an easier time building muscle. Can also affect improve mood and libido as well. Salt fluid imbalance. I won't get into this too much, except to summarize by saying that almost without exception, patients I see who've been told to drink plenty of water and eat plenty of salt are getting too much water and not enough salt. And it's not an easy sell to explain to somebody that they're dehydrated from drinking too much water. But if you're constantly thirsty and no matter how much water you drink, you're still thirsty, you need to be drinking less and eating more salt. So replacing plain water with electrolyte drinks are probably the simplest solution, limiting how much plain water you drink. Try to stay away from friends and well-meaning do-gooders who tell you that salt is bad for you. I found that very few people actually need fludrocortisone, which is a synthetic hormone to trick your kidneys into holding on to more salt. Most people just need more salt. So mast cell dysfunction is now clearly associated with the hypermobility syndromes and can cause symptoms essentially in all organ systems. Overactive mast cells can aggravate your autonomic problems, can disrupt sleep, as I mentioned earlier, with the histamine effects on sleep, and can contribute to fatigue as well. And typically, dietary measures as well as pharmacologic measures are going to be necessary to control mast cell symptoms if they're really overactive. So, final word about stimulants. Many well-meaning physicians, unfortunately, are inclined to offer people with unexplained fatigue stimulants to help them feel better. In uncommon cases of EDS and the hypermobility spectrum disorders, where patients are chronically have low blood pressure, stimulants can raise their heart rate and raise their blood pressure and be very helpful. But using stimulants to treat fatigue is really something that needs to be avoided. If you're tired because you're in pain or you're depressed, you're not sleeping well, your autonomics are not working well, your mast cells are out of control, you need to address the underlying cause of fatigue. Taking a stimulant to plow through it will just make your fatigue worse and cause you to crash, aggravate your autonomic dysfunction. Again, really tempting, and physicians who are guilty of the sin of trying to be helpful will often recommend stimulants. And once you're on them, then you're really stuck because staying on them is making a bad situation worse, and getting off them is difficult. The exceptions are modafinil and armodafinil, which are not physically stimulating and not habit forming, can improve alertness and productivity. As one of my patients years ago said, it doesn't give me more energy, but it helps me be more productive with the energy I have. These tend to be very hit or miss drugs. In other words, some people find them helpful and some people find them don't. Some people don't, but they're worth trying because the side effects are uncommon, and when they're helpful, they really can be significantly helpful. So hopefully now you have some game plan as to how to approach fatigue, how to manage treating it by identifying as many of the factors that are contributing to it, and addressing as many of those as possible in a comprehensive treatment program. And again, leave you with one more graphic for those of you who are picture people. I tell people to think about your body having its own gas tank, having an energy reserve that you need to draw from to be active. Sleep is your major thing that puts gas in the tank, and then all the stresses you see listed below, the chronic pain just sucks energy out of the tank, plowing through fatigue, just makes your fatigue worse. Any degree of dehydration makes your fatigue worse. Your body's got to work harder to overcome that. And then cognitive work, physical work, emotional stresses, you know, in the Washington, D.C. area, getting in the car and driving anywhere is stressful. Watching the news on TV is stressful. It's pretty obvious how you can easily fall into a situation where you're net negative every day and your fatigue gets worse. But conversely, if you can improve your sleep and limit these stresses that are draining energy, then gradually your energy level will improve. And with more energy, you can be more active. With more activity, your mood will improve. If you're more active during the day, your sleep will improve. If you sleep better, you'll have more energy. And this is how you can reverse the vicious cycle. And this is how fatigue in patients with Ehlers-Danlos and hypermobility spectrum disorders gets better. So thank you for your attention. And I think I'm happy to take some questions if time permits.